Hello and welcome to my teach on cranial nerves. My name's Hannah Beare. I'm an intercalating medical student, so I'm going into 5th year of medicine next year. This teach is aimed at people in kind of the early years prior to clinical exposure really. So I'll be teaching some of the basics to do with cranial nerves and showing you examination of cranial nerves because I've got my brother here who will be acting as a patient for me. So let's get started. By the way, I'm not a neurologist, but I do have quite a lot of experience. I've had a couple of OSCEs on the cranial nerves already, so I should be able to give you some top tips. Okay, so to start off with, what are the 12 cranial nerves? Well, they're pairs of nerves that run on the underside of the brain, and they control motor and sensory modalities of various parts of the head and the neck. So they come in pairs and there's 12 of them. So there's a lot to learn. So I'm going to give you a bit of an overview about how you might go about beginning to remember these nerves and what they do, and then how you can relate that to your clinical examination. So how are we going to remember all 12 of these nerves then? So they come a lot of the time with Roman numerals. So it's worth having a little read about your Roman numerals if you aren't quite sure. Don't worry, I didn't know Roman numerals in first year of medical school either. Really simple though, so go and look it up. So they're numbered 1 to 12, and they run through olfactory, optic, oculomotor, trochlear, trigeminal, so on. You can read for yourself. And a clever way of remembering all 12 is via a mnemonic, because it's kind of handy to remember what order they come in, and in an exam setting, such as like a multiple choice or something, you can use the mnemonic to help you remember what number each nerve is. Before it becomes second nature, the more familiar you get with them, the more you'll be able to remember, oh yes, facial nerve, that's nerve number 7. So the mnemonic that I've used is ooh, 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 to touch and feel very good velvet, ah, heaven. Bit silly, I know, you can probably make your own mnemonic to help you remember it better, but that will just help you to remember the actual names of the nerves and what order they come in. So another thing that's quite useful to remember is what modalities each of these nerves carry. So are they a sensory nerve? Are they a motor nerve? Or do they fulfill both functions? And for this, we of course have another mnemonic. Some say marry money, but my brother says big brains matter more. So where you see an S, that of course means it's a sensory nerve, M, motor, and B means it carries both modalities. So I used to, in our multiple choice exams, which we have in Exeter Medical School, write those down on a bit of paper in multiple choice exams, so I definitely couldn't get things wrong. It just helped me to get things straight in my brain. So it's important to remember what the nerves are called, what number they are, and what modalities they carry. It's a good place to begin. So there's lots of summaries of all of the cranial nerves and exactly what functions each of them fulfill. I'm not going to regurgitate that here for you right now because you can have a good read for yourself. It's basically just important that you remember a few key features about each nerve at this stage, and you can remember broadly what they do. I don't think it's worth in the early stages getting bogged down with exactly what nerve does exactly what portion of innervation of the taste of the tongue, for example. You can get quite bogged down with all of that detail. So just keep it simple for now. And Geeky Medics has a really good overview article with a little PDF table that you can download at the end, which is good for starting out. So I'd recommend that. So let's dive into now some of the actual nerves and what they do. So I'm going to start by talking about some of the nerves that come first. The olfactory nerve is nerve number 1. That does smell. So let's park that. Let's move on to nerve number 2. That does vision. So most of the nerves at the front end of that table of 12 are to do with your eyes, sensing the light, and also moving your eyes around. So I think that's a good place to start. So nerve number 2, cranial nerve number 2, is the optic nerve. Now this is only a sensory nerve. This senses the light coming into the eyes. Then all of the other nerves to do with the eyes are movement nerves. So the oculomotor, trochlear, and abducens nerve all move the eyes. Okay, so sorry, I'm just getting a bit, Zoom is very new territory for me. So first of all, let's get my brother over here to help me. What I'm going to do, guys, is teach you a little bit about what each nerve does and then show you how it's examined, and we'll go through like that, if that works. So cranial nerve number 2, the optic nerve, is to do with how we see things. And so our vision can be divided into visual fields. You guys might be familiar with this diagram. This shows how the optic nerve runs through the brain to send the messages to the brain about the light that it receives. So it's important that when we're assessing our vision of the patient, we can determine whether they can see and what they can see at what distance. That's their visual acuity. That's the Snellen chart with the numbers. But it's also important that we assess their visual fields. So whether there's any parts of their visual field where they can't see, because that might give you a clue as to whether there's any lesion anywhere along the optic tract. So where the optic nerve runs into the brain to relay that sensory information. Visual inattention is another thing that you can assess, which is to do with what a patient can and can't see and what they are paying attention to in their visual fields, but that's not routinely done as part of a cranial nerve examination. So we are going to assess vision and visual acuity. That comes first. I'll do all the eyes in a minute. I've got George waiting here. Let me just run through a couple of other things first. So another thing that we need to assess when it comes to vision is the pupils and what the pupils are doing. There's 2 nerves which control the pupils. There's the optic nerve, which is only a sensory nerve. So that carries the light information to tell the pupils what to do. And then there's the oculomotor nerve, which carries the motor information to the pupil to tell it what to do, whether to constrict or dilate. And these are under both sympathetic and parasympathetic control. So pupil dilatation is a sympathetic motion and pupil constriction is a parasympathetic motion. So just remember that, that can come in quite handy for exams. Pinpoint pupils, opioid overdose, parasympathetic. Okay, so then we're going to talk about eye movements. I'll show you all of this and bring it all together in the examination in a second. Sorry, George, you will get to do something in a minute. So just to go over eye movements then. So these are under control of 3 different cranial nerves. So we've done the light detection, visual fields, we're now onto eye movements. So there's various muscles that move the eye and they're each innervated by something different. So I've color coded them here on my slides so you can see them easily. So you've got these 4 muscles here, the rectus muscles, which are these straight muscles on either side of the eye. And they control moving the eye up, down, or from side to side in vertical planes of orientation. And then you've also got these oblique muscles, which are to do with intorsion and extorsion of the eye. Now, this all might seem quite complicated to remember because they're all innervated by different things, but I've got a handy way of remembering them. So I remember them with the chemical formula expression LR6SO4. Now what that means is the lateral rectus muscle is innervated by cranial nerve 6, which is the abducens nerve. And SO4, the superior oblique muscle, is innervated by cranial nerve 4, or the trochlear nerve, which also conveniently means pulley. So, because you can see there's a little pulley there on that superior oblique muscle. And then everything else is innervated by the ocular motor nerve. So the superior rectus, medial rectus, inferior rectus, and inferior oblique are all under ocular motor control, cranial nerve 3. So that's eye movements. And if you'd like a bit of a better explanation about exactly how those muscles move the eye and where, I refer you to this really good YouTube video here, which summarizes it better than I can. I'm going to focus now on what we actually need to do to examine those nerves to do with the eye to see if they're working properly. So cranial nerve examination can seem a bit daunting. So I have a way that I structure it to make sure that I can remember it, because actually it's a relatively easy examination to do. So I think about the body parts that I'm examining rather than getting bogged down with the nerves when I'm actually sat in front of my patient. So I think of it in terms of systems. So I think first and foremost, smell and eyes, then face sensation and movement. Then I think hearing and balance, tongue and swallowing, and then finally I'm on the home straight doing my head and neck movement. This just groups the nerves together in a way that's a little bit easier for me to examine rather than just going 1 through 12. And I find it just helps me to remember it better, and it makes it flow a bit better. So when might we be doing a cranial nerve examination? Well, it's indicated if a patient comes in with headaches, any visual changes or stroke-like symptoms such as facial drooping, unilateral weakness or paralysis, any problems with their speech or swallowing, or any hearing or balance changes. So there's various scenarios where we might want to pull out this examination. So let's begin examining. So first of all, you'll go into your OSCE station and you must make sure you read the OSCE brief, because sometimes they might only ask you to examine nerves 1 to 6 or whatever. So you must make sure you're doing the right nerves rather than just running through the whole examination if it's not asking you for that. So we're going to start off with an introduction. Let me go and sit here. Can I reach the mouse from here? I can. So I'm going to explain what the procedure involves and gain consent. So hello, George. I'm not meant to know your name, you're just a patient. Hello there, my name's Beare. I'm a 4th year medical student at the University of Exeter, and I've been asked by the doctor today to come and examine your cranial nerves, which are the nerves that provide innervation to your face, your neck, your hearing, your balance. Basically, I'll be examining your face today and asking you to do a few things. Does that sound like it would be okay with you?
That's fine.
Could I just confirm your name and date of birth, please?
George Beare, 20th of November 2000.
Lovely, thank you. Is it all right if I call you George?
That's fine.
Great. So at this point, I'd of course wash my hands and get my bits and bobs ready. So for the purposes of this examination, I've got a few things. Obviously, when you're in an OSCE station, look at what they've given you. What they've given you will give you a clue as to what you should be using. So here I've got a pen torch. I've got a neurotip. Well, I've got a pencil for now. I've got a bit of cotton wool and I've got a tuning fork. So we'll be using all of those today. I've also got a tendon hammer somewhere on the floor. Okay, so I've got everything that I need ready for my examination. I will wipe it down to make sure it's all clean before I use it on the patient. I've confirmed the patient's identification, gathered my equipment. Now, the first really important thing that you need to do for cranial nerves is make sure that your chairs are positioned correctly. I have been a mock patient on somebody who's failed a cranial nerve examination before for examining a patient supine on the bed. Don't do that. You want to be facing the patient. You want to be roughly the same height. Unfortunately, my brother's a little bit taller than me, so he's not quite at my eye line, but ideally your eyes should be meeting. Your knees are just about touching. You're about 1 meter away from the patient. Don't worry, this is my brother. Social distancing doesn't apply here. Okay, so that's a really important thing. You want to be orientated in the right way. So let's begin my examination. So first of all, I'm going to ask him some questions. Have you noticed any changes to your sense of smell recently?
No.
No. Asking that question is enough to assess the olfactory nerve, cranial nerve 1. We don't routinely ask patients to smell anything. I presume often we don't have things to smell on hand. Now we'll move on to eyes. Have you noticed any changes to your vision lately?
No.
Any double vision or blurring of your vision? Okay. Do you normally wear glasses?
No.
No. Okay. My brother doesn't wear glasses. If your patient did wear glasses, you'd ask them to put their glasses on, but have a good look at their eyes before they put their glasses on, because they'll need them to be able to see you properly and for the examination to go on properly. So, first of all, I'm going to have a good look at my brother's eyes. So I'm looking for any asymmetry. Am I seeing any drooping of the eyelids? Is the pupil size symmetrical? Any gross abnormalities there? Then I'm going to move on to visual acuity. So cranial nerve 2, the optic nerve. Normally, there's not a Snellen chart provided to you in an OSCE setting, so I found that a good substitute, and a substitute for on the wards, is getting someone to read your name badge. They kind of should be able to read your name badge from about 1 meter away. I'm not wearing mine right now, but George, could you please just read what it says to me on my name badge?
Beare.
And then I get him to cover the other eye, so you should have been covering one eye.
Oh, okay.
So can you read what it says here?
Beare.
And then I turn it over and get them to read something else. So that's fine. If they can't read your name badge, that's when you then progress onto something such as count fingers, visual acuity. So how many fingers am I holding up?
Fine.
The thing is, we know that George has quite good vision. Finger count vision is actually very crude. If you're at that point, you've clearly already lost a lot of your vision. So it's not really a reliable enough initial test for somebody who's got presumed healthy visual acuity. So you do that one eye at a time. Now we're going to move on to looking at the pupils. So for that, I've got my pen torch. I'm just going to stop. Should I stop sharing the screen? That's fine. Okay. So George, I'm just going to be shining a light in your eye now. It might be a little bit uncomfortable. Please tell me to stop if so. Patient comfort is important throughout. It doesn't matter if you do the examination a little bit wrong. You must keep your patient comfortable and safe. So we're going to be looking at direct and consensual pupil responses. So what that means is I'm going to be shining a light into the left eye to start off with and looking at the left eye to see that pupil constricting. What should also happen if I shine the light in the left eye is the right pupil should also constrict at the same time. That's called the consensual response. So what I would do is pop my hand in the middle of his face. You can just move over a bit, just this way so you can see a bit better.
Yeah, sure. Angle it up.
Yeah. Okay. So I'm going to be shining the light into your eye now. I'm popping a hand down the bridge of his nose so the light doesn't bleed from one eye to the other. I'm shining the light in the left eye. I'm looking for pupil constriction. I'm then shining the light in the left eye. I'm looking at the right eye, and the right pupil constricts normally. I then repeat that on the other eye. We can then also do the swinging light test to assess the pupil constriction. And what that tests for is a relative afferent pupillary defect. So obviously for pupils to constrict properly, they must first sense the light and then using the optic nerve, and then send a motor response through the ocular motor nerve to tell the pupil to do the constriction. So if you have a problem with the optic nerve, I might shine the light in the left eye, swing it to the right, and the pupil would dilate if I had a relative afferent pupillary defect. So the pupil would dilate in the affected eye, and that would be a sign of an abnormality, which of course is not present in my healthy patient. Cool, so we've done pupil responses. The last thing we should do there is then accommodation. So that's looking at what happens to the pupil when you focus on something close by and far away. In a healthy person, when they look at something close up, their pupils should converge, so come together and get a little bit smaller, so constrict. So George, I'd ask you to just look at that light switch behind me on the wall. And then when I tell you so, just to focus on my finger, which I'm holding about 30 centimeters away from his face. So look at the light switch and look at my finger. And I was just observing for the pupils converging and constricting. That was all fine. Okay, perfect. So we've done that. Now we're going to go on to visual fields. So to do this, you want to be sitting directly in front of your patient, and you're effectively comparing your visual field with their visual field. So George, could you just cover one eye for me, please? And you want to be covering the mirror image on yourself. And then using your hand about 1/2 meter in front of you, and you want to be keeping it in that same 1/2 meter plane the whole time. George, I'd like you to tell me when you see my finger come into your visual field and when you see it coming in, okay?
Yeah. Yeah. Yeah.
Now I'm going to change hands.
Yeah. Yeah.
Okay, they must keep their head still and look directly at you at all times. And then you'd repeat that on the other eye. It's worth practicing that one, as it's really easy to let your arm drift forwards and backwards, which makes the test a little bit less reliable. And you want to make sure that you assess all 4 quadrants of vision on both eyes. And yeah, this trick of you swapping your arm over so you can use the other eye is use the other arm, sorry, is a really handy one to remember. Thank you very much. Cool, so that's visual fields. I use my finger to test that, but if provided in your OSCE, you could use the pin with the white end to do the visual field assessment. If in your OSCE as well, you've also been provided with a pin with a red end, that's telling you to assess the blind spot. And similar to visual fields, you'll be comparing your vision with their vision. So you'd get them to cover one eye and moving in from both sides with the red pin very slowly. You'd ask them when they see the red pin and to tell you when it disappears for them, and that shows their blind spot. If they've got a large blind spot, that could be pathological. So again, you're just using your vision to compare to them. So that's assuming your vision is normal as an examiner. Okay, so we've done those special tests for the eyes, and the one that I like to leave till the end to make sure that I've done everything else before I do this one. I like to keep this one to the end, so it's like a marker of, right, I'm finished with the eyes now. I do eye movements last. So in order to do that, you ask your patient to sit still. And again, looking at your fingers, they need to keep their head still and follow your fingers as you trace them in an H shape. Observing for smooth eye movements and looking to see whether they have any nystagmus, which is where the eyes kind of shake around a bit. And you also want them to tell you if they experience any double vision throughout doing that test of mapping out the H in front of them, because that could tell you that there is a problem with one of the nerves that controls eye movement, so cranial nerves 3, 4, or 6. So those are all the eye examinations that I would recommend. So we've done all of those ones there. So what do we move on to next? Well, next I like to examine the face. So I think of doing the trigeminal first, because that's cranial nerve number 5. So the trigeminal nerve is the nerve that is concerned with innervation of the skin of the face and also the cornea. So it's divided into 3 key areas: the ophthalmic, maxillary, and mandibular branches. So when we're testing the sensation of those, we need to make sure that we test all 3 on both sides of the face. So normally you'd use a neurotip for this, which I don't have, so I'm going to be using a pencil. Principle is the same. So George, I'm going to be assessing the sensation of your face now. I'm going to be touching you with this little sharp neurotip. Shouldn't hurt, but please tell me to stop if it is hurting you. Mm-hmm. So this is what it feels like. So you want to try the neurotip on a central area, normally just above, between the 2 clavicles here. This is what it feels like. Can you feel that okay? Mm-hmm. Yeah. So what I'd like you to do is close your eyes and just let me know when you can feel this touching your skin by just saying yes.
Yes. Yes. Yes. Yes. Yes. Yes.
Brilliant. So he had his eyes closed throughout. Now, George, I'm going to repeat this with some cotton wool. So you just take a bit of cotton wool, do the same thing, tell them what it feels like on a central point, and then we'd repeat for all branches. It's okay. I don't think we have to show them that as well. So you do it with cotton wool too. Then while you've got your cotton wool out, it's a good reminder to say to your examiner, I would normally assess corneal reflex as well, which is done by putting a tiny bit of cotton wool onto the cornea and observing for your patient blinking reflexively. But of course, that's a bit uncomfortable, so it's not routinely done. So you'd say, I'd normally assess the corneal reflexes. If your examiner wants you to do that, they'll say, oh, go on then, do it. Normally they'll say, yes, yes, that's fine, and you don't do it. Next, the other thing that the trigeminal nerve does is provide motor innervation to the muscles of mastication or chewing. So, George, I'd like you to clench your jaw for me, please, and unclench it. And I'm just going to feel the area of your forehead and your jaw while you do that. So I'm feeling up here. If you clench, unclench, you should feel the temporalis muscle contracting. And then you also feel at the angle of the mandible, and you should feel the masseter muscle contracting. George, could you open your jaw for me, please? And I'm just observing that it's open nice and symmetrically. And now just don't let me close it. Just pushing it with my hand. And just swing your jaw to one side and resist me here. And swing your jaw to the other side and resist me here. There we go. We've assessed power of the mastication muscles as well. For completeness now, we will assess the jaw reflex, which is another job of the trigeminal nerve. So we do that by just placing a finger on the chin. I'd just like you to look towards me, George, and just relax your mouth. And you just, onto your finger, which is just underneath the lips, gently tap your tendon hammer, and you should see the jaw reflex nicely there. A very brisk reflex would be pathological. A brisk closure of the mouth would be pathological. Okay, so we've done face sensation and muscles of the jaw. Now is a good time to do the motor parts of the face. So this is the facial nerves job. Pardon me, it's very easy to mistake the facial nerve for controlling sensation. That's the job of the trigeminal nerve. So first of all, I'm going to have a good look at George's face. I can't see any obvious drooping or asymmetry, which might be a sign of facial nerve abnormality, such as Bell's palsy. The facial nerve also does an element of taste. So have you noticed any changes to your sense of taste, George?
No.
No, that's normally enough. And now we're going to assess the movements of the face. So there's the facial 4 movements, which I'm going to show you up close. So you ask the patient to raise their eyebrows like this, surprised, to purse their lips, to blow out their cheeks like a puffer fish, and also to do a big smile. So George, could you raise your eyebrows for me? And just purse your lips. Big cheesy grin, and puff out your cheeks. We're then going to oppose some of those motions. So George, could you raise your eyebrows for me, please? And I'm just going to try and push them down. Okay, puff out your cheeks, please, and don't let me push them in. That's great. And we can do the pursed lips as well. Purse your lips for me, please, and don't let me pull them apart. That's great. So that's the facial nerve done, that's in charge of all the movements of the face. So this is our checklist. This is what we've done so far. So now is the right time to move on to hearing and balance. Now, technically, any hyperacusis, so loud noises, that is actually the job of the facial nerve, because the facial nerve innervates the stapedius muscle, which controls how loud we hear things. But I just ask this here and now because it just makes sense to think body systems for me at this point. So George, have you had any trouble hearing lately?
No.
Have you had any trouble with hearing sounds too loudly?
No.
No, brilliant. So we're now going to assess the hearing, and we'll do each ear one at a time, covering the other ear. So what I do is do you want to move just to face the camera now? So I'm just going to cover one of your ears, and I'm going to whisper a number, and I need you to tell me what it is. So I'm slightly rubbing the tragus on his other ear, not too vigorously. That'll just muffle the sound in the ear that I'm not testing. So I'm going to whisper a number. Can you tell me what the number was?
No.
Oh, right. It's clearly been blasting loud music. Let's try again.
44.
Oh, you got it this time. And we'll do the other ear.
65.
Might do another number, but we don't want to embarrass you, do we? Okay, then we move on to doing Rinne's and Weber's tests with a tuning fork. Rinne's and Weber's tests are important in determining whether you have conductive or sensorineural hearing loss. So don't worry too much in a cranial nerve exam. They often won't ask you to distinguish between the two tests. So just think about putting the tuning fork in the right place for now. So I've got a fork here to demonstrate. One thing that examiners definitely hate is if you bash the tuning fork against the metal chair leg. It's far too loud. You really don't need it that loud. So the best way to make your tuning fork make a noise is just to lightly pinch it, and then it will start vibrating. So George, imagine this is vibrating, okay? So first of all, I'm going to start by doing Rinne's test. And I remember the way around it goes. Rinne's is right by the ear. That's how you remember it. So George, what I'm going to do is I'm going to place this tuning fork just on the bone behind your ear. I'd like you to tell me that you can hear it. I'd like you to tell me when you stop hearing the sound. And then I'm going to bring it in front of your ear and you can tell me whether you hear it there. Okay?
Okay.
So vibrate my tuning fork right on the ear. So can you hear that?
Yeah.
Tell me when it goes away. It's gone away?
Stop. Yeah.
Then you bring it towards the front of the ear, and it should be louder in front of the ear than it was on the bony prominence. Was it louder in front of the ear?
Indeed.
Indeed it was. So there we go. That's good. That shows there's no abnormality because air conduction should be superior to bone in somebody who has no conductive hearing loss defect. We then do the Weber's test, which is where, well, I repeat that on the other ear. Then we do the Weber's test, which is where we vibrate our tuning fork again, and we put it right in the middle of the forehead there. And George, do you hear it louder in either ear?
No.
No, you shouldn't be able to hear it louder in either ear. If you do hear it louder in either ear, it may be a sign of conductive hearing loss, where something like a big plug of wax is acting like a resonance chamber and causing the conduction of the sound. So here's just a summary of Rinnie's and Weber's tests for you. You can find that explained in many places online. I won't bog you down with it here. Basically, for the purposes of the cranial nerve examination, remember to place the tuning fork correctly in the bony prominence behind the ear, and then remember to ask them when it stops, when they stop being able to hear it, and then you bring it in front of their ear, which should be louder for them. Okay, so we've done hearing, but I missed out balance. This is real life medicine, folks. It's because I'm trying to perform at the same time. So that was the hearing part of the vestibular-cochlear nerve, cranial nerve 8. Now I need to assess your balance, George. So could you get up off your chair, please? And what you need to do is you need to ask the patient to walk on the spot with their eyes closed, but you need to be ready to catch them if they fall. So George, could you close your eyes, please, and just walk on the spot for me? And you'd be looking for any drift. George is absolutely fine there. That's great. Take a seat for me, please. So we'd sit back down. And there's a reason you do the cranial nerve examination in a specific order, to avoid the patient having to get up and down all the time. Okay, so that's the vestibular-cochlear nerve done. We've done hearing and balance. We're now going to move on to the later cranial nerves, so tongue and swallowing, which are basically glossopharyngeal, vagus, and hypoglossal nerves. So I don't actually have a tongue depressor on me, so I'm not going to touch your tongue today. But basically, the first thing you need to do to assess the glossopharyngeal nerve and the vagus is to have a good look at the soft palate. So the area at the back of the mouth where you see the dangly bit coming down, that's your uvula. When you say ah, you should see the soft palate move up like a roof coming off a house. And that is normal, and it should be symmetrical on both sides. So George, I'm just going to shine the light into your mouth, please. Could you just stick your tongue out and say ah? Nice contraction there, and his uvula is nice and central, so that's all normal. Have you had any problems with your swallowing recently?
No.
Okay. Could you just swallow for me, please? And could you just cough for me, please? Seems a bit weird coughing on me in a COVID world. Okay, that's normal. He's got a nice cough there. You'd also turn to your examiner and say, I would assess the gag reflex, but obviously that's not routinely done. That would be done with a tongue depressor or something just towards the soft palate. So that's fine, we've got that done. Also, George has been speaking to me today. I've not observed any hoarse voice, so I don't think he's got any vagal nerve pathology. I don't think he's got a problem with his recurrent laryngeal nerve branch of his vagus nerve. No hoarseness there. Good. Okay, so now I'm just gonna, to finish that bit off, have a good look at the tongue just to check for any asymmetry, any deviation, or any fasciculations of the tongue. Okay, so the tongue is nice and symmetrical, there's no fasciculations, it's not deviating to one side or the other, which would be a sign of a hypoglossal nerve lesion. Now I'm going to just test the motor capabilities of the tongue. So George, I'd just like you to stick your tongue into one of your cheeks, please, and just don't let me push your tongue away. And just the other side. Like that. So if you guys couldn't see that properly, George was just putting his tongue in his cheek like this and resisting me pushing it. that's fine. So that assesses tongue power, which is the hypoglossal nerve. Okay. So these are the nerves that we've done so far. So we've got one left, the accessory nerve, which is, I think, my personal favorite cranial nerve, to be quite honest, because when I learned about it, somebody used some GIFs of Beyonce to help me remember, because she is the queen of the shoulder shrug and the hair flick, which are the chops of the traps, the trapezius muscles at the back, and the sternocleidomastoid muscle. So that muscle which is strap-like that goes along your neck here. So to assess this, we need to see whether George can shrug his shoulders. So George, could you just shrug your shoulders up and down for me, please? He has recently dislocated his shoulder, so might cause him some pain. That's great. And could you just turn your head from side to side, please? That's brilliant. And now we're going to resist those movements just to check that power is intact. So could you shrug your shoulders up, please, for me, George, and just don't let me push them down. That's great. And turn your head to one side for me, please. And don't let me resist me. Didn't phrase that very well. And turn your head to the other side, please, and just resist me. That's great. Thank you very much. Okay. That concludes the examination. Thank you very much. I'll just, at this stage, wash my hands and thank my patient. So we've done all of the cranial nerves. So of course, I'm going to thank my patient, say that concludes the examination, wash my hands again, and present my findings to my examiner if that's appropriate. So that concludes my teach, guys. Thank you very much for watching. I've tried to make it quite quick, so if I've whizzed through anything and got you confused, please feel free to ask me a question. Thank you very much, George, for being my patient. Okay. And my top OSCE tips that I would give to you guys are just practice, practice, practice on anyone that will let you practice on them. It's really good to practice with somebody who maybe isn't doing medicine, because it makes you realize that some of the instructions that you might be giving aren't necessarily that easy to follow. As in, George, sometimes I wasn't very clear, right? I'm a little bit rusty. It's been a while since I've done an OSCE, as I've been intercalating for the last year. But just make sure that the instructions that you're giving to your patient are clear and they know exactly what you're asking them to do. Also, make sure you warn and explain them before you do anything, but explain to them before you do anything what things might entail, because you'll obviously be coming at them with relatively sharp things in the cranial nerve examination, such as the neurotip. Also, always remember to dispose of your waste appropriately in an examination. So if you have a neurotip, make sure you pop it in the sharps bin. And I cannot stress this enough, make sure you're sitting in the correct position, because you will definitely fail the station if you're not sat appropriately with your patient, particularly for the eye examinations. So thank you very much, guys. I hope it was helpful.
Thank you.
Take care.